What if everything you thought of health and wellness suddenly changed due to a hidden breathing problem that you were unaware of that affects every system in your body? Improper breathing habits are often overlooked in medicine. I'm Dr. Jenny from the Hobson Institute, and this is the Breathing Lab. Hello, everyone. Welcome to the Beauty of Breathing podcast. My name's Dr. Jennifer Hobson, and
I am Dr. Martha Cortez.
And we will be interviewing Dr. Karen Davidson.
Oh, Dr. Hobson, this is Dr. Karen Davidson. She is the leading national expert in Rhinomanometry. I have to send you with an accent. And she's leading there in England. There's much more of this utilized than in America. So she is here to teach us and really bring us to a higher level because you need to measure
your nose, right? Let me tell you.
Resistance.
Let me tell you a little bit about her bio, just so you have a little background about her. Dr. Karen Davidson has held many positions in the medical device industry for more than 25 years, specifically in the ENT and the sleep markets, in addition to more than 30 years of clinical experience, including service as a flight nurse in the U.S. Air Force Reserves and committee member for various otolaryngology meetings. Dr. Davidson serves as the VP at GM Instruments, with a special interest in and published on the technology of objective nasal measurements, nasal physiology, clinical application, reimbursement, health economics, and health policy. She's actually also an adjunct professor at Central Michigan University and the Liberty University. So welcome, Dr. Davidson. Thank you so much for taking the time to educate us and be with us this morning.
Good morning, and thank you for having me. This is a pleasure. Thank you.
I want to say thank you, Dr. Davidson, because I may sound like a commercial, but the Rhinomanometry has actually made such a difference in the practice. Even though I'm a neonate, we are being able to differentiate those children that the parents say there's nothing really wrong. Everybody says they're fine. They're just breathing through their mouth and everything is good. So then I put them on the actual, I said, well, let's measure it.
So you have this in your office,
yes,
Martha? Okay, yes. So you've been working with Dr. Davidson.
Yes.
Okay.
I'm a neonate though, but it's made such a difference 2 weeks ago. So the mother insisted there was nothing wrong. So what I did is measure it. It's an opinion. All these people are giving opinions. I measured it. It shows that he's already mild apneic, OSA, obstructive, already going on moderate apnea. So this kid, despite the mouth breathing, despite supposedly the clinical exams, he's already obstructing. So he's getting 20% less oxygen every day, every night. And on top of it, it's also showing already obstruction, which means his IQ is going down. I don't care what, and his reflexes. And so I referred him to Dr. Gilden for the physical therapy, who then evaluated further and said his reflexes, his primitive reflexes are still there. So the kid is doing badly.
Yes.
That was because one measurement. She wouldn't believe it until the measurement.
And you know what, Dr. Martha, you bring up such a valuable point, especially in infants, because they will nasal and oral breathe for about 6 months. And this is part of our book as well, about the tongue ties and how this all develops. And we know that the first bone that is created in utero is the maxillary bone. And it's interesting how over time and growth and development that the wee bit of cells that we are to where we are today is such a huge spectrum of breathing. And to that end, when we look at the history, just in measurements, objective nasal measurements, this has been around forever, literally, since 1894, actually, when they looked at, they looked at refrigeration and vapor that you were breathing out of your nose. But more importantly, we, from biblical times in Genesis 2:7, we were meant to breathe life through our nose.
Wow, I didn't know they had that.
Yeah, and so when you look at the trajectory of how this has all come about and the historical perspective of it, we go back to 1894. And then 1938 is when they looked at the mirror. So a lot of myofunctional therapists will use the mirror to see how much condensation is
Right.
coming out of the nose, right? That was back in 1938. And then 1958 is when the first description of nasal patency came about, and that was from Dr. Semtrak. And then it goes into more. So we all know Dr. Cottle maneuver.
Absolutely.
In 1968, he brought the concept of rhinomanometry into the world of rhinology.
Huh.
And we fast forward, 1970 is when
Wow.
the first computerized rhinomanometry came to market. Very archaic looking. Remember the old DOS systems in the 70s? Yeah. So that's what it was. Then you go through all these different modifications, where rhinomanometry was FDA approved in 1990. So it's been around for 30 years, but quite a difficult concept. It was new, and when you look at crossing the chasm between early adopters, late adopters, and those that are middle of the road, we're technically changing a behavior. So we have that behavior, or that behavior recognition, and that practice recognition. We've been trained to do this. This is all we know, and we're not going to do anything new. And so in 2010, there's a standardization committee that did a supplement published in Rhinology, as a matter of fact, that said, hey, y'all need to be doing objective nasal measurements.
Effective measurement.
And nasal flow. Yeah, nasal flow is important. Fast forward. Now remember, back in the early 2000s and 90s, when rhinomanometry came to fruition, it was an old, obsolete kind of system. So there is a lot of negative literature out there, a lot of negative research, negative connotations as far as reimbursement from just a few companies, because it didn't look at the trajectory of development, where in 2015, Dr. Vaught and his team looked at over 35,000 readings of rhinomanometry, 4-phase rhinomanometry. And that was a pivotal turning point, because they found that 4-phase rhinomanometry is clinically comparable and compatible to the subjective symptoms presented by patients. What does that mean? What the patient is telling you can be found on the numeric output data of rhinomanometry. And that was, again, published in 2015. And then in 2016-17 is when, in my scenario, GM Instruments updated the software to have the 4-phase rhinomanometry aspect. So that's been the historical perspective and how this has all come to fruition. And that's what's brought me to where I am today.
Karen, can I ask you, because, there's lots of people listening that might not know what this is. What is rhinomanometry? Can you tell us what it is exactly for the people that have no clue what this is right now?
Yeah, sure. So there is some confusion on the market. I'll just point that out. When you say rhinomanometry, oh, I've used that forever. And I hear that. Karen, I've used that forever. Okay, tell me more. And when I say tell me more, they're talking about acoustic rhinometry, which is an acoustic pulse sound wave that comes out a sound tube, is bounced off the nasal passages to measure the geometric areas of the nasal passages. So it is a structural measurement. On the other hand, you have rhinomanometry. And I think that the longer the word, the better the technology. And so rhinomanometry is an actual and they're both non-invasive, but it's a non-invasive test that looks at your nasal function during active breathing. What does that mean? You are measuring the transnasal pressure drops against a pressure gradient during, it's very quick. It's like 15 seconds. It's very quick.
Wow.
It's really fast.
And so you can see that. You can do it anteriorly. You can do it posteriorly. And anterior, you do it just one nostril at a time. And posterior, you do it bilaterally. You can see it bilaterally. But what does that tell you? It looks at the retroglossal, retropalatal pressure changes when you're breathing. And then when you look at the grand scheme of things, nasal resistance dictates the genioglottal muscle. It's also attached in its own way in connection to diaphragmatic breathing. So there's a whole sequelae of events that occur just because nasal resistance. That's why breathing, function, nasal function, not nasal structure, rhinometry, but nasal function rhinomanometry is so important. And when you look at the physics and the theory of the nasal aerodynamics, the first, we look at upper area resistance. You hear that a lot in the sleep world. UARS, UARS. Well, UARS is dictated by nasal resistance and the increase in negative intrathoracic pressure, which causes a collapse in the back of the throat. So the collapsibility is not a structural measurement. It is a pressure flow relationship.
That's very important.
That's only measured with rhinomanometry. You need a pneumotachometer, you need a flow head, you need pressure. So when you put the mask on, it's a mask, and it's got like 4 tubes, for example. And I say about the NR6 rhinomanometer because that's the only one available that's FDA approved. There have been some in the past, but they're no longer, either the company's not a business or they're not really that, prominently used here. So we're it, for lack of a better way to say it, we're it. So you'll see 2 tubes come out, red and green. That's your flow. And then you see your pressure, and that's the black and the blue ports. And when you have a mask on, it's looking at the pressure changes between the nose and the back in the pharyngeal area. It can detect that. But the other beauty of it is that you can look at the data outcome, which we'll get to. But you can look at how well someone is nasal cycling. That's important, especially when you're looking at treatment options. But you can also see in the allergy world the different mucosal membrane component to it. So that's kind of differentiation between the two. So one is just a pulse sound wave, like a sonar up your nose, like on a ship. And one is active breathing, transnasal pressure drops and changes that's detected through the computer software and measurement, and then results shown your data output.
So my data output, there was a patient that's been through multiple dentists, multiple things, but a very simple thing showed up. So there's these lines, and there's these beautiful sine waves like this. They could be short within this XYZ axis, and they could be short. Short is most likely mild apnea to moderate to even severe apnea. When they're longer, because there's more flow and less resistance, that's where it's normalized. It's towards the normal are the longer ones. But also, when you see one and you see on the inspiration it's an open loop, okay, your external valve is collapsing. There is a valve issue. So now, do you send them to an ENT, or can you improve the nasal by opening it up? Because that Cottle test would be positive on that person because they would collapse. The other thing, fascinating, is not only that, but if it goes outside these 2 lines, now you got a posture issue. Did you know that the nasal resistance causes posture issues? The nasal. You got to get the physical therapist involved because it's not just the nasal resistance. You're going to, yes, the external valves, but then the posture is showing up, how the nasal is causing the posture. You could call it scoliosis. You can cause it smooth compensation, unparalleled compensation. Fact is, it's the nasal.
When you
know
don't
what, Dr. Martha? Oh, sorry. Go ahead. John.
No, I was just going to say, when you don't use your nose to breathe, it changes your head position, right? And that starts changing the spine compensates all the way down the chain. But, and the muscles, all the muscles start to change. The muscles that you use to breathe. When you mouth breathe, it's all neck and chest muscles. It's these extra accessory muscles that we shouldn't be using. Our heads start to move more and more forward. We're already forward with these computers, but that even causes the tension to stay.
That's that whole survival mechanism of going like this. And the typical, on a woman, the UARS, because this compression of the C1 into the occiput shows up as anxiety, depression. Can't breathe, but something's off. And it could be mistaken as depression, anxiety, put them on medication. So now we have a woman, a UARS woman, who instead of looking at the breathing, they're putting on medication. So now they're disengaging the corpus callosum. It's not giving the information correctly because of these so-called low-dose antidepressants that will just stop the anxiety at the brainstem. Not good.
No. So Dr. Martha, you have a great point because I just had this, long conversation with a chiropractor friend of mine, and the bantering back and forth. It was rather entertaining. I was like, we should write a book. But when you look at structure, and this is why I say, and I get denigrated to a degree. They're like, oh, you're just a nurse. You're not a real doctor. Okay, I'm not an MD, but there's a lot of experience. I've been working with this for 5.5 years and studying this. And what's really interesting is that I always say that that your static measurements are irrelevant in the presence of nasal resistance. Well, that doesn't make sense, Karen. Well, it does. For example, pharyngometry is very big on the market. A lot of dentists use it. And they look at anterior, posterior, the AP movement with the oral appliance. Well, hang on. And Dr. Jennifer, you know this well. There's more to an AP measurement and movement. And when you look at nasal resistance and posture, if you use a static measurement tool like pharyngometry, even CBCT, that C-spine issue or a lesion or even a shoulder issue, if you're tilted, will cause an impression on that reading that can also give you an erroneous measurement. So you're going to measure and treat somebody based on this reading when there's a posture problem. Now, I worked with an actual sleep doctor in a dentist office and was training him on rhinomanometry. I said, let's play, Dr. Justin. And he did it. He was slouched over and he was like 0.42 Pascals. I said, sit up straight. And he did. And he was perfectly normal. I said, test my hypothesis here. Let's look at the TMJ joint. And I said, just put something like a bowl and bot, just something that will manipulate the mandible, this little hanging, apparatus that we have on our face. It's just hanging there, right? So he gets a device. He puts it in. He goes from perfectly normal to 0.41. I said, congratulations. You have proven my hypothesis. That ineffective treatment could have caused now a new problem. And if you look at the data in Dental Sleep Practice magazine from 2017, it clearly says there are 200,000 ineffective oral appliances done a year. Now, if we just tested their breathing, we would know who's a true candidate and track their progression in breathing by watching that pressure drop.
You're saying that the appliance that they put in just to do that test caused reduced nasal breathing?
Yes. His nasal resistance went up. In fact, there's a study from Dr. Hawley who looked at oral appliances in AHI. And he found that the AHI was increased by 50% with an oral appliance in their mouth. So there was something that was blocking that flow. There was an obstruction there just in the oral cavity. There's an orthodontist brought this study to my attention. I said, how fascinating, because here we are putting all these different oral appliances in. Are we looking at the materials that are being used? Is it a bone-to-bone? Is it a tooth-to-tooth kind of device? What are we using here? And that's why Dr. Martha and I and a few other people are going to look at this. At what point, when you put a device in, at what point does that transnasal pressure drop? Is there an increase when you put that device in there? Now, when you look at the position of people sitting to supine, recumbency plays a huge factor in nasal resistance. In fact, it increases. And so through rhinomanometry, you can look at these different parameters, all through research, not me. Yes, people say you have a vested interest. Of course I do. I work for GM, but even more importantly, I'm a clinician I'm still licensed. I have a duty to educate the public and practitioners that, hey, we can do better by helping our patients breathe better. And so you can look at somebody from sitting to supine and determine just in the change of nasal resistance if they're an OSA patient. So there's been some talk and discussion about flow. Okay, well, spirometry, like nasal spirometry, and we have that at GM, but nasal spirometry, let's talk about that for a minute. They'll say, oh, it's just as good. No. First of all, it's majority of it is oral. And if you look at expiratory flow, it's like lungs, asthma, and things like that. But when you look at the echelon, so to speak, about nasal function and breathing, you've got nasal resistance that is dictated by nasal pressure drops that is going to dictate the velocity that's going to ultimately dictate nasal airflow and the limitations. So why start here when you can start up here to see your resistance?
Right.
Why would you look at flow when you can look at resistance?
Yeah. And follow it, monitor it, put the appliance in.
Yeah,
Even put
exactly.
it in children who get ear infections, who are having tonsils issue. You can put little turbos and look at the resistance. So we're modifying some of the things we do. Just in anything. This is the whole thing. It's not device dependent. It's not company dependent. It's just how does the patient respond to it?
Right. And you know what, Dr. Martha, and when you look at the grand scale, let's talk about children for just a brief minute. Most children are diagnosed with ADHD between the ages of 5 and 8, right? And I've worked in children's mental health back in the 90s. Now I'm dating myself. I feel awful. How many children did we unnecessarily medicate with Focalin, Metadate, Ritalin, all these ADHD medications that were stimulants that probably affected their sleep when it was really a breathing problem? So my point is that now we have rhinomanometry. We can measure all these children in this range, and we can look at, is it, because the symptoms are similar. ADHD and OSA symptoms are similar, right? But what we know is that daytime sleepiness is directly related to high nasal resistance. And interestingly enough, I'm currently doing a retrospective study looking at data in children with an oral appliance, like a tooth positioner, and how the parents are answering the questions. And the data, when we publish it, it's amazing. You look at this, you're like, whoa. Some of the kids had their symptoms decrease with an appliance and some didn't. So now we get into this bigger discussion between pediatricians, psychiatrists, psychologists, and dentists. This web of efficiency in breathing is growing and growing and growing. Just beyond physical therapy, like Dr. Hobson, and positioning. I mean, it's a spider.
No, and children,
networking
not, as
crazy.
Dr. Hobson will talk about this, children are not simple because they have nasal resistance, but they also had a tongue tie. Now you got to do myofunctional therapy, but they don't know how to breathe out their nose. They don't know how to posture correctly.
Yeah.
And then the adhesions, the ties, decreases their flexibility. They lift like this as a dentist. So it goes all the way from toe toes. And we have to absolutely require a physical therapist in there. Not necessarily an osteopath. That's a little thing I have to say.
The function, you got to train the function, right? The function of the nose. And these kids are all hyperinflated. Like their ribs are high. They're up. They're breathing up in their chest. And they are not getting good oxygen flow. They're not exchanging their gas in their lower lobes like they should be. But, you know, Dr. Karen, what I wanted to ask you, what do you do? What do you do with this information? So once you have the flow and once you have this measurement, what are you saying to recommend for the practitioner, for the parents? Like what should we do with this information?
So that's a great question. So when you look at this data output, it looks very overwhelming. It really does. You have this beautiful graphic that's a quad, 4 quadrants. You go from inspiration to expiration, right and left, right? So, when you have that high resistance, it looks like a squashed X, like Dr. Martha was saying. But when you look at the mean resistance, the end all be all is the mean resistance. And now the software has been updated. So you can see in the little box, it'll say mean resistance, right? So in my infinite wisdom and craziness, I thought, you know what? There's no software out there that can help practitioners and guide them through what does this data mean? What do I do with it now? Okay, great. I see the graphic show they can't breathing, but what is all this numeric nonsense? What does all this mean? So that's why I created the Daphne scoring system. I did. So now it'll launch next week, and it's going to be a web-based access. It's like an annual licensing agreement that you can get the license to go in behind the firewall and work with actually the three technologies for nasal breathing: rhinomanometry, and the peak nasal inspiratory flow meter. And so now this software has software capabilities. So the practitioner can go in and enter that mean resistance or rhinometry reading. And when you hit the arrow next, it'll walk you through the algorithm. Is that normal or abnormal based on research? Is it normal or abnormal? And I looked at over 744 studies to create this. So it's been a monumental task. But so once you understand where they are on that spectrum of nasal breathing or nasal disease or dysfunction, that'll allow you to understand, okay, allergist, is there something that I'm seeing? So for example, patient comes in, you always do a baseline. And then, and this is according to Quad AI, the American Academy of Allergy, Asthma, and Immunology. And they clearly say when you do a nasal provocation test, which is what it's called, anything you spray up the nose is going to be a nasal provocation test. You have the patient do your baseline, do your spray, wait 10 minutes, and then remeasure them. If you see like an antibiotic therapy, an area under the curve, as far as efficacy, if you see a large area between your first congested reading and your second or your decongested reading, that's a mucosal membrane component, right? So that's going to be where I can pull in allergy. And if it's less than a certain amount, percentage of change, that could be a structural problem. But like Dr. Martha pointed out, you can also see they call it nasal valve hysteris. That's the term they use. But it's a nasal valve phenomenon, and you can see that loop. So that would tell any practitioner that remember, 2/3 of resistance occurs right here in the first 3 centers of the nasal vestibule area. So no matter what you do, stand them on their head, lay them sideways, until that area is fixed, you're still going to have that velocity, flow, and resistance problem, right? That's where your ENT will come into play. So I like, and I know it's not promotional, but I like the VIR procedure where it's a radio frequency remodeling of the nasal valve. And I'm sure there's other techniques out there, but I'm not, that's what I'm most familiar with from my ENT background and
I
world.
actually had that done to me a few years ago. Yeah, to just
tell
kind
me,
of, yeah.
what'd you think? Did you like it?
It made more space in the nasal cavity, so I think that helped me with my flow.
Mm-hmm.
But yeah, this was after a nasal septum surgery. Was improved my nasal breathing, but not completely. That actually helped more. So
interesting. Yeah. And Dr. Martha and I have talked about that, like on a CBCT, you can see a posterior deviation, right? And if you try to expand, like do a transverse expansion, people think, oh, you can open up, drop the maxillary nasal floor and just kind of open everything up. But what's interesting, and again, I've sat in just in my whole career, hundreds and hundreds of sinus surgeries. And now I'm thinking back, how well are they breathing after that? Are they going to come back for surgery again? Are they going to be a repeat revision case? And interestingly enough, about 12% are within the first year. So if we can really look at how someone's breathing, if there's that posterior deviation, can we get that fixed by the ENT, then come back to the dentist? There's this whole ebb and flow of communication and collaboration among all specialties. There really is.
Big collaboration, and dentists are stepping in because in the posterior, I know I'm not supposed to be, as a dentist, able to touch the posterior at all. It's supposed to be an ENT. And when I use the MSE, the skeletal expanders with the mini implants, you can change the posterior. And I'm in the process of measuring it now because it takes time to do these cases.
Right.
So it's really, so now when the nose is that bad, I don't send immediately to an ENT. We get the interdisciplinary examination conclusion, expand them, widen. But the question, will we only widen towards the anterior or have actual cognitive thought about, is it possible for the posterior on that person? Will it make a bigger difference? Let's measure it.
Yeah.
Interesting. Yeah.
The MSCs are it's a newer device, but I've seen that the images of before and after and how much that nasal cavity actually widens. And I don't know. I want to say it's 4 millimeters or around four to
Oh, you can
six,
do a lot.
even more.
But the question is,
So
can they sustain it? Because now they have to learn how to breathe, and
yeah,
you've taught them how to breathe. And I find that it doesn't, like everything. Like when I went to a program for the nose for surgeons, and I brought up the idea is that they all talked about the relapse. It could be 30%, it could be 70%, and it's patient dependent. It's not necessarily surgeon dependent because they're saying it might be surgeon.
Interesting.
So it's a human. It's not simple. But if they grind, there's still an issue in their brain. And that I learned from sleep physicians. There's a neurological issue. It's not easy to say it's just the oxygen desaturation, the oxygen that's dropping. It's not a simple thing. But with measuring the nasal, you can understand who is next in the interdisciplinary team that we're going to be working with. Who is going to be a priority? Can't give poor patient 8 people to work on them.
no. And
Yeah,
when you send patients, sorry, Karen, real quick, when you send patients to the Hobson Institute to do the breathing clinic retraining, it's like people are not used to cleaning their nose and using their nose. They think their nose is supposed to work without any help if it's stuffy. I'm like, no, you have to create that airflow or else it'll just continue to be congested.
Accumulate.
Right?
Mucky, like a pipe.
and the cleaning of the nose, like it's hard to get some people to do that, to actually start getting that airflow through. But anyway, Karen, what were you saying?
Oh, no, I was going to say that Dr. Martha brings up a good point because this came up on social media. They were talking about nocturnal bruxism. Like, y'all, it's connected to the nose, the bruxism. And there's that limbic association. So your brain is trained to grind until it retrains itself. This whole concept of breathing, I'm glad that it's getting a lot of recognition, but we're missing the mark on measuring nasal function. And I say, trademarked, you don't know how well you're breathing until you measure how well you're breathing. Think about that.
Absolutely. Absolutely. Yeah. Because people just like bypass the nose, they bypass it. A lot of times they don't address it, You're right.
It's this little tiny organ, but it is so powerful, there's really the nose knows.
The nose knows.
The nose, I did a talk about that last year. The nose knows. It truly does. Yeah.
It's so big too inside. Like you think it's just this, but it's like within the face where the turbinates are, the sinus, like the whole cavity. It's so made for what we need it for is nasal breathing, but we don't use that whole part of our face.
Well, I have officially declared it as its own organ. It's own tiny organ.
But it's also one of the most important primitive, I call it organs, the olfactory bulb. It is so primitive and is so emotional and so limbic that makes the nose even more interesting because it's more than what it is. Like melatonin. Melatonin was just a little molecule. Melatonin is a hormone like. So we're going to discover more about the nasal and the olfactory and the limbic.
Yeah.
It's shockingly. So the more we know what happens, the less we really know.
Well, right. And it's interesting too, is you talk about the olfactory bulb. When people are like, oh, I can breathe. And when I would work with different doctors and ask them, well, how well do you know that they're breathing? Well, the patient said they can breathe. But when you look at the nasal air, when you look at the nasal aerodynamics, and if you don't have flow up over that olfactory cleft, that's still improper breathing. That's abnormal breathing. That's how we're supposed to breathe, up over the olfactory cleft area. That influences speech, smell, taste,
memories.
So we
I know.
Dr. Karen, where do people, like for the people that are listening that aren't clinicians, because we have clinicians and we have non-clinicians also listening, where do people go to get this done? Who does this?
Sure. So the way back when, and the now obsolete, it was mostly ENTs, allergists. Allergists are still predominantly using that because of the nasal provocation testing and to see how well the air flows. And if there's an environmental issue, an allergic issue that's causing these mucosal membrane issues. ENT, not so much, but it's mainly been in the EU, Europe, Asia, UK, Australia, off the chart. And what's interesting, it's more so than the US. US, we're just stuck in this conundrum of these protective behaviors. This is the way I've done it, and I'm not changing ways. So this is my Goliath. We are making headway. There are some very big, world-renowned institutions and practitioners that are finally getting it. And this is a voice in numbers kind of thing too.
Yeah.
But we do have world-renowned institutions and practitioners that are adopting and kind of, the light bulbs are going off like, you might be onto something. So, yeah, it's a daunting task, but we're getting out there. So there are, to your point in question, there are practitioners out there. The dental world is starting to pick up on it.
Yeah.
We do have, there are distributors that carry this product around. So it's a matter of just, asking your doctor, I want this test. And that's the thing. We have to be more proactive in our own healthcare. Can I get this done?
And if you're a doctor and you want more information,
yeah. How do we connect to you? How do we connect to you?
Website? Is there an email?
Sure. So you can go to gm-instruments.com. They have a training video so you can actually see how this test is done, the steps it takes to set one up and actually do the test. As far as the numeric and clinical portion, that's where I come into play. So all my contact information is on GM Instruments website, but you can also go to Karen D at gm-instruments.com and send me an email that way. And then on the clinical side and education, I have FACT, Healthcare Consulting Group. So I can do that off the cuff because you have to look at the liability issues between the manufacturer, kind of dictating what's normal and not normal. We have to be careful about that and oversight, right? So it's FACT, FACT, and all of my information is on there as well.
That's great. I think this has been a wonderful podcast about how we can really learn more about nasal breathing measurements. I never realized how much you could actually quantify and objectively measure this. So
yeah, it's really interesting. I mean, all this time in the medical world, we measure blood pressure. Everything's been numerics, wound dressings, and I've worked with a lot of physical therapists, amazing physical therapists when I was a CRNI doing home infusion. And we'd work together in collaboration with wound care and everything's measured, blood work as a measurement. Why are we not looking at breathing? We screen vision, we screen hearing, but we're not screening our breathing. Why? I think a lot of this could be a preventative approach, right? But we just have to get out of this mindset and just step out of our comfort zone. But more importantly, Dr. Jennifer, is that this does have a revenue stream. If you look at 20 years of CMS reimbursement over this time, there's been an incremental increase. And if you recall, back in 2011, 2012, when the ACA, Affordable Care Act, came into play, a lot of sleep PSG testing reimbursement was dropped by 25%. Not rhinomanometry. Every year we got it. In fact, from 2021 to 2022, a physician fee, we got a 4%. There's a 4% increase in reimbursement. So it's around 61. It's going to be MAC location dependent, right? But for the national average through CMS, it'll be about $63. The highest EOB that I have seen was out of New Jersey at $88.
Okay. And that's if you bill for it at that's from a dentist billing for it or a medical doctor billing?
Medical. It's all medical. Mm-hmm.
Okay.
Mm-hmm. Yeah.
Okay.
Yeah. And there was some argument. I had a doctor that said, care's not reimbursable. Well, there are, so like Blue Cross Blue Shield National does recognize, so the CPT code for this is 92512. It's 92512. And you can, go ahead and check. So for example, Blue Cross Blue Shield in Alabama, I have an orthodontist who bought a narrow system down there. And Blue Cross Blue Shield Alabama covers it. Anthem, the national level, they observe it. But again, each subsidiary is different, but a majority of them do, and Medicaid does as well.
Great.
So it's a
Great.
win-win situation.
Yeah, you're helping your
Good for the
patients
patient.
identify the nose,
Yeah.
and you can
Mhm.
actually get reimbursed for it. That's great.
Yes, yes.
Okay, any last comment, Dr. Cortez, for
Oh, we
Karen?
covered so much.
I know.
Excellent.
Okay, so
Really.
stay on for a second, and we're gonna close out. I just wanted to say thank you so much for coming. Hang tight, and everyone
Thank
who's
you.
listening, thank you for
Thank
your
you.
listening, and please let us know how much you enjoyed the show by leaving us a review. Thank you so much.
And thank you. Thank you for this platform to get the message out. I truly appreciate it. It's been a pleasure. Thank you.
Thank you for listening to the Breathing Lab with Dr. Jenny.